Today, we will be talking with Professor Katherine Kaminsky, PhD, researcher and lecturer of 20 years, and author of over 100 peer-reviewed publications. Katherine is not only the former dean of Trinity College's School of Nursing in Dublin, Ireland, but the government's appointed academic expert for Ireland's National Drug Strategy Implementation Group. With degrees in math and philosophy and biomathematics with statistics and epidemiology applied to healthcare, she was selected after a European Union's wide competition to serve as the EU expert on the scientific committee of the European Monitoring Center for Drugs and Drug Addiction, and currently serves as its vice president. Her personal research interests are substance use along with child's well-being. Katherine, welcome, and congratulations on your new book. It's called Addictions Debate, Hot Topics from Policy to Practice, published by Sage in the UK.
Oh, thank you very much. I have it here.
Asking you to describe Ireland's drug strategy is a pretty broad question, but I would like to move into sort of the policy and maybe education and
Yeah, we have quite a comprehensive national drug strategy. It's a new strategy. It was developed in a partnership approach. So we do have a history of partnership. And when I say partnership, I mean around the table. I have a beautiful table here, but it is challenging partnership. But we did have the community sector, the voluntary sector. We would have had an organization called the Family Support Network. So family members were at the table. We do also have a service user organization called ISHCA. They were at the table. They kept us in line in terms of our language and non-stigmatizing language. The Department of Health, Department of Education, Justice, Customs, Police, academic expert myself. We had a very comprehensive partnership that developed the National Drug Strategy with our overseen by the Department of Health and an independent chair. So I've just published a paper, an open access paper on that in the International Harm Reduction Journal, and where I talk about that process and how challenging it was. People coming from different philosophies and different approaches. But I think we ended up with a good national drug strategy. But our problem now is in the implementation and making sure that those actions that were agreed get implemented.
Is prevention much of a part of that? And I guess I think about even prevention with, say, our middle school students.
Yes, so I'm not sure if I heard your question correctly, but in terms of education, is that what you asked?
Out of your response, I was wondering about prevention being much of a certain debate sometimes about the issue of prevention and strategies to deal with it. I just didn't know if you could speak to the philosophy or.
Oh, prevention is one of the sort of the pillars. We would have sort of, pillars. So prevention would be a pillar within the strategy. The Department of Education would have been very crucial, very important in that, because how are we going to bring prevention into, say, schools if we don't have the buy-in, as we call it, from the Department of Education? So I'll give you an example of one action in the strategy that had to be negotiated. The school buildings are a great resource for, say, urban disadvantaged communities. But school buildings close, when school ends. So in terms of the school building being a community asset, so we were looking to have school buildings open in the evenings where we could have information, we could run, sports, more sports facilities. We could use the facilities of the school in order to provide not necessarily direct prevention, but more sort of additional services for urban disadvantaged youth. So just getting agreement from the Department of Education to keep the schools open, because that's a change in practice, and there's going to be a cost. They have to have the caretaker and the security and so forth. But that's an action that was agreed in the National Drug Strategy, was to actually use the resources that we already have to better value. And that I thought was a really clever action, because it's not all about more investment. It's about using the investments you have in a better way. We also, across Europe, just when you mentioned prevention, again, at the EMCDA, we do have a prevention sort of best practice site, whereas there's a group across in the European Monitoring Centre, and we actually look at prevention programs and we evaluate them. We evaluate the evidence, and we provide sort of signposting to what works, say in family environment, school environment. So there is the prevention sort of database of what works available, open and online at the EMCDA, the European Monitoring Centre for Drugs and Drugs Addiction. So that might interest some of your participants.
So one of the questions that posed by one of our team here was speaking to that. I mean, how you view the various institutions, not only across Ireland, but across perhaps a larger area of Europe, how well you coordinated, shared data, analyzed data, and to the extent that you could actually put that into practice. I don't know if you have anything further you'd like to add relative to that.
Yes, there's two aspects to that. So at a European level, we have 5 indicators, so that each country pays into the European Union Monitoring Centre and we monitor these 5 indicators. So they are general prevalence, there is treatment demand indicator, there's the deaths indicator, the infectious disease indicator, and then problem drug use prevalence. So those are 5 key indicators. They're a great resource for policy development and for the EU Action Plan on Drugs. So we can see across those 5 main key indicators how Europe is doing and how, if one country needs help. For example, say for instance, we had a brief spike in our Irish number of HIV cases, and partly due to homelessness, believe it or not, and the rise in chemsex. So we were able to bring that to Europe and look at what other countries were doing in terms of that. So on a European-wide, we do have those 5 indicators. Within Ireland, we do have a challenge with sharing data. So, so in terms of the treatment systems, they don't all speak together. We do not have a unique identifier that we can link a person across systems. So if somebody is, there is a central methadone treatment list, yes, they have an identifier for that. But if I'm in treatment now in North Dublin and 6 months later I go into treatment in South Dublin, they don't necessarily know. So we are failing there. So how that's impacting is the challenges for our care pathways and our processes. So we're relying very much on, we do have protocols for care pathways, but sometimes the ball can be dropped. And that is a challenge, yes.
If you had to pick one aspect of the care there in Ireland that you would like to promote, what might it be?
Oh, I would have to say probably our harm reduction philosophy. I'm quite proud of it because we weren't always a harm reduction philosophy country, and we've evolved. And as we've evolved as a nation, so we started off really with an abstinence-based philosophy, but over the time when we saw that that was actually harming our people, our own people, we moved towards, and we had the courage to move towards a harm reduction philosophy. And I think you can really see that now in terms of, safe injecting, needle exchange. And we're moving even forward now again, and we're talking about, in a sense, harm reduction plus rehabilitation and recovery. But recovery in the wider sense, not recovery as abstinence, perhaps it may be for some, but recovery in terms of getting your life back. So we're talking now about harm reduction plus recovery. So you may be stable on opiate substitution treatment or your methadone, you're getting your life back, but maybe you still have mental health challenges. So that's our challenge, is to deal with those wider issues. But I would say that's what I'm most proud of, is the fact that we have been open to change and we've responded to need. In terms of something I'm not so proud of, probably is the fact that we're still struggling with our sort of care pathways, that, people can be left out in the cold. If you're in prison and you're coming out of prison, we can maybe, ensure that you're going to get your opiate substitution treatment when you leave prison, but you might have nowhere to live or nowhere to stay, nowhere to go. So that is a challenge, is, really looking after the individual and ensuring that people are not getting lost, that we do all of this good work. And then, this, particularly in Ireland at the moment, is a homelessness challenge, that people then are getting lost along the care pathway. So that would be our current challenge, big challenge.
Do you see much of a difference between the sort of rural sections and the urban sections in terms of that? I know here in the U.S., West Virginia, who's had quite a bit of unemployment, and some of the states and areas, not only West Virginia, where unemployment is high, you often see the higher levels of opioid use and, unfortunately, overdoses. I was just wondering if you saw a similar pattern.
Absolutely, yes. I mean, we started off with this as an urban problem, but as time has progressed, it has moved out. Housing in Ireland is in Dublin city, our capital city, is very expensive. So people moved to rural areas, and you can actually see, I had a PhD student look at this, you can see when you map it, the spread of substance use along the major highways.
Right.
Definitely we are seeing a rural problem now, without a doubt. Every corner of rural Ireland, there is a problem with drugs. And the problem is also, even though services may be available, you can't access them because maybe you don't have the transport, or you don't have the money to get the bus into the nearest town. So if you're living in a very rural area, there may be somewhere in the bigger town nearby, it could be 20 miles away, but you have to get a bus. If you don't have a car, how do you get to the service? So there are, real practical challenges for people who are rural and who are using drugs. And that's something that sometimes services and maybe policymakers don't fully appreciate, the actual practicalities. If you're a mother with a child or a father and you're not working, you don't have the bus fare to go 20 miles to the treatment centre. So there may be a treatment centre, but how do you access it? You don't maybe. So those sort of things are real challenges.
Well, you do seem ahead of us in many respects, or at least in some respects, relative to, for instance, there is not the prevalence of the safe injecting centers here in the U.S. But I guess I am struck by how similar we are, much more so than difference in some of these sort of trends.
Certainly in Ireland, because you're our neighbours, we're strong links. We're always looking to the States and seeing what's happening there. Because generally what's happening there happens here maybe 10, sometimes even 20 years later. But certainly, I remember, a long time ago, reading one of the sort of seminal texts, Hunt and Chambers, in the 1970s, talking about waves of heroin use leaving urban areas and moving across rural areas of America. And, we only had an urban heroin problem at the time. And of course, now it's all across rural Ireland as well. So generally what happens there happens here. Another example would be the HIV and AIDS. So we saw what happened there amongst people who use drugs. But in that case, we were able to react quicker, and we brought in needle exchange. So we developed our harm reduction philosophy in response really to the challenge of HIV and AIDS amongst people who use drugs. So although it happened in the States, we were actually forearmed. So it didn't happen to the same extent here. We were forearmed. So we're always looking to you to see what's happening there.
Great. One sort of along these lines of problem, obviously very often part and parcel with addiction is just the stigma of addiction. I was wondering if you could speak to what you see there, and not only the amount of stigma, which I'm assuming, but efforts that you have perhaps made to sort of help with that problem.
Yes. Stigma is a huge problem. And I was actually thinking about this because we actually have stigma in different ways. So one would be maybe sort of systemic stigma within services. Mm-hmm. So services, perhaps, say emergency room, emergency department services, if you're going in as a person who uses drugs, do you get access to your methadone? There would be still a lot of stigma within the services and people experiencing services. another big area of stigma really is actually self-stigmatization.
Right.
A lot of my own personal research that I'm doing, I'm finding this amongst people who use drugs. So they're being stigmatized by the services, but also they're taking that on board and self-stigmatizing. I remember interviewing a young mother once who's had huge challenges, and she was talking about not contacting her children's school. And I said, of course you can ring your children's school and find out, how your children are getting on. And she had such self-loathing. And I knew when I was interviewing her that there was something she was sort of holding back, I could just see it. And when we turned off the tape, she was saying to me that she'd actually been raped while she had been on alcohol and drugs. And this added to her own self-stigmatization.
Yes.
And addressing that stigma, not just within the services. We do also have, there's an organisation called Citywide, and they actually have an anti-stigma campaign at the moment. And we're actually developing with people who use drugs a training module for services, so that we're hoping it'll actually be delivered to government services, health services, justice services. So we're actually developing, and it's led by the people who use drugs, and we've done work with them, and we're developing a training module on stigma. So there are things happening, but it certainly is a big problem, yes. But I should tell you that the community clinics can be very innovative. One of our sort of community voluntary clinics was what's known as Merchants Quay, Ireland. And it was originally, Merchants Quay was originally run by the Franciscans, but they were actually the most progressive. So they would have one of the largest needle exchange services. They feed hundreds of people every day. They have homeless services, because that comes from their philosophy of, looking after the poor. So they were actually very progressive. And they have won the tender for our first medically supervised safe injecting centre. It's actually not a government clinic, but a government-funded community clinic. So they're being very progressive.
And this is in Ireland?
Yes,
right.
Yes. So we've just had it's gone through law and everything, and we've had a tender, and it's just been through. Did have challenges with planning permission. Actually, the Merchants Quay Ireland is situated beside a primary school, but it's all the people who live in that region. It's right in the city centre here, and we're going to have our first medically supervised safe injecting centre, where people will be able. We have a problem with street injecting, and people will be able to go in and inject and safely and under supervision.
Now, would you say that that's the norm across Europe in terms of having these safe injecting centers? I know
it's becoming the norm. It has been challenging, but we actually have, I would say, between 80 and 90 safe injecting centers across Europe, and they have been evaluated. The European Monitoring Centre has evaluated them, and they have been found to be effective. They've been found to be cost effective in terms of reducing overdose and reducing bloodborne viruses. So they are not the answer to everything.
Right,
they are just one part of a whole treatment system that is necessary.
I feel like I could talk with you for hours more, and I know we're limited for time, but I thought I'd wrap up with whether there was any sort of hot topics from your book that you would like to sort of mention that maybe we haven't gotten to.
Oh, you're very good. Well, I suppose, the reason I wrote the book is because there is so much evidence out there, right, and I'm exposed to it through my work with Europe. I'm visiting yourself in Yale recently, and so I was aiming to bring that evidence together, because, as I say, the debates, say, for example, on safe injecting, there's a lot of bad evidence and, anecdotal evidence. So the good evidence is that, say, it does work, but it's not, it doesn't cure everything. There's a big debate on the decriminalization, and there's a lot of confusion over what's decriminalization versus legalization. Right. What are the differences? Yes. We're sort of working more towards the decriminalization model across Europe rather than what we're seeing in the States, more legalization and regulation. Right. So there's some of the very hot topics.
Yes, certainly a very timely
topic
here we didn't even get to.
Yes, yes. So I debate those, and hopefully it will be a resource for students, professionals who are doing continuing professional development, and for the services. And we're actually launching it tomorrow, so we're looking forward to that.
Oh, well, congratulations. And I look forward to seeing you again.
Yes, you'll have to come
Thank
visit
you.
us.
Yeah, thank you so much for taking this time to join us and giving us a bit of perspective on
You're
not
very
only your
welcome.
country, but the European Union as well.
Thank you. You're very welcome. It's my pleasure. Always a
Thanks.
pleasure.